Okay, next section deals with the restrictive diseases. Now, I realize that this can be a particularly difficult topic, or quote-unquote a difficult topic, and medical students are a little bit weary of this topic because it's sort of hyped up to be particularly difficult. But I actually don't think that this section is that hard, and I'm hopeful that you'll agree with me by the time we reach the end of the section. So the first principle that you have to keep in mind is that in a restrictive diseases, you're restricted from filling the lung. There's a problem with the ability to fill the lung. Now remember that in an obstructive disease, the problem was the ability to empty the lung. In a restrictive disease, the problem is the ability to fill the lung. If you can't fill the lung, obviously the total lung capacity is going to go down. If you can't bring air into the lung, the total lung capacity measures how much air you can actually hold in the lung. And if you can't put air in the lung, obviously the total lung capacity will be down. In addition, the forced vital capacity will be down. The forced vital capacity is the amount of air that you can blow out after breathing in all the way. So you take a very deep breath and blow out as much as you can. That's the forced vital capacity. And that will be down because if you can't bring air into the lung, you're going to have a problem. You're not going to be able to get that much air out, right? So that you can't fill it, so therefore there'll be less coming out. So the forced vital capacity will be down. The forced expiratory volume over a 1 second period, the FEV1, will also be down. And that, again, is the amount of air that comes out in the first second after you breathe all the way in and then blow out. So when you're blowing out, that very first second, that's the amount of air that comes out in that first second. And if you can't fill the lung, you're not going to be able to get as much air out in that first second period. What's important to note, however, is that this ratio, again, both the FEV1 and the FVC are going down, but the ratio actually increases. Now, what do I mean by that? Let's go back to normal for a minute. Remember that the normal forced expiratory volume over a 1 second period is 4 liters. So that when I breathe in all the way and I blow out, in the first second I'm going to blow out about 4 liters. And the total amount that I can blow out, the forced vital capacity, would be about 5 liters. So otherwise stated, normally about 80% of the air is blown out in the first second. Now what happens in a restrictive disease is that my forced vital capacity, the amount of air that I can blow out totally, would go down. So for example, let's say that that goes down to 4 liters. And my forced expiratory volume, the amount that's going to come out in that first second, is also going to go down, but it's not going to go down as much relative to normal. So that maybe it becomes 3.5. So when, 3.5 over 4 is like greater than 85%. So this becomes greater than 80%. And that's important because that's one of the classic hallmarks of these particular disorders. And it's pretty easy to remember because basically that forced expiratory volume over 1 second, what increases it is the fact that when you get a restrictive disease, you often have a lot of fibrosis in the lung, and that fibrosis in the lung increases the elastic recoil of the lung, and that increase in elastic recoil is going to allow you to be able to squeeze air out more quickly over that first 1 second period. And so that's one way to think about it. Another way to think about it is when you get all that fibrosis, you're not going to get collapse of any of the airways, and as you don't get collapse of the airways, then the air is going to be able to rush out of the lung more quickly, because the acceleration of the air does cause some compression or collapsing inward of the airways, but that's not going to happen because the fibrosis is going to trap all of those airways open. So that's another way to think about it. Regardless, you do need to know that that ratio is increased, and remember that in the obstructive disorders, the ratio was decreased. And again, that was the hallmark of those obstructive disorders that we've already covered. You can go back and review that if that wasn't clear. Most commonly, the restrictive diseases are going to be due to something called an interstitial disease of the lung. Now, what are interstitial diseases of the lung? These are disorders in which you get fibrosis of the interstitium. And what's the interstitium? Well, if you go back and recall, remember that you've got these alveolar air sacs down in the exchange portion of the lung, and the wall of these alveolar air sacs is super delicate and thin. Now, the reason you want that to be super delicate and thin is because you're going to exchange oxygen and carbon dioxide across that barrier, so you want a super thin barrier. In an interstitial fibrosing process, you get fibrosis of the interstitium, and it's fibrosis of the interstitium that thickens that barrier, and the thickening of the barrier then is going to prohibit the ability to exchange gases very well. That's going to be one problem. But another problem is you're not going to be able to fill that lung because it's going to be hard to open that fibrosis when you want to fill this airway. And so there's going to be a problem. There's going to be a restrictive problem, an inability to properly fill the lung. So that's the most common cause of restrictive disease, interstitial fibrosis. Now, another way by which we can have a restricted filling of the lung is by having an abnormality of the chest wall. For example, let's say the patient's obese, right? So as the patient is trying to fill the lung, they've got to blow open that chest wall. They've got to fight the force of the chest in order to open the lung completely. And so if there is a lot of force in the chest wall, for example, due to obesity, that force in the chest wall is going to prohibit the lung from being able to open and fill as much. And so that would also result in a restrictive disease. Now, the first of these disorders is called idiopathic pulmonary fibrosis, and the key disorder here is that you get fibrosis of the lung interstitium. All right, idiopathic pulmonary fibrosis, where you get fibrosis of the lung interstitium. This is what it classically looks like, and you can see here, this is probably as close to normal as we have on this slide. This is the normal alveolar air sac, and you can see that the wall of the alveolar sac is very thin and delicate. Now notice here, you've got another alveolar air sac here, but this wall is way too thick. This interstitium has become fibrosed. Here you can see how much fibrosis there is in the interstitium. And so that's classic for this disorder called idiopathic pulmonary fibrosis. Now in this particular disorder, what happens is you get cyclical lung injury, and nobody knows why, hence the term idiopathic. But our current understanding is that with this cyclical lung injury, you get cyclical healing. And remember that one of the key mediators of healing is TGF-beta. If you go back and recall from your lectures in inflammation, I mentioned during inflammation that when the macrophages come in, the macrophages can do different things, like they can create additional acute inflammation by secreting IL-8. They can induce fibrosis. They can call in the healing response. And at that point, I told you that there were two important mediators that allow for calling in of the healing response. And one was TGF-beta, and the other one was IL-10. And so in this particular case, you can see that TGF-beta is important for the healing response. And so the injured pneumocytes can also release TGF-beta, and that would induce fibrosis. And that is what is thought to drive the process. It's TGF-beta from the injured pneumocytes that induces the fibrosis. That's important to know. Now remember, when a patient has this kind of interstitial fibrosis, you have to first exclude other causes. So, for example, you have to make sure that it's not due to some drugs, like bleomycin is a high-yield example, or amiodarone is another high-yield example. You've got to exclude radiation therapy, which can also cause an interstitial fibrosis. And you've got to exclude other causes as well. And once you've excluded all the other causes, then you would call it idiopathic pulmonary fibrosis. Now, clinically, these patients are going to have shortness of breath that's going to get worse over time, and it gets worse over time because the fibrosis progresses over time. At the same time, they're going to have cough. If a lung CT was performed, you would see fibrosis on that lung CT. Very important to know is that the fibrosis initially begins in the subpleural regions, right underneath the pleura of the lung, and eventually, over time, it can progress to involve the entire lung. When it involves the entire lung and there's diffuse fibrosis throughout the lung, that's called honeycomb lung. Now, there's no way to remove this fibrosis, and so the treatment is lung transplantation. And that's because we have no way of removing the fibrosis. Another disorder that could result in interstitial fibrosis is called the pneumoconiosis. Pneumoconioses are basically disorders in which you get fibrosis due to some occupational exposure that then activates the macrophages to lay down fibrosis. Let's start with small particles. Now, the notion is that if you've got big particles present in the environment, when you breathe in, the mucus and the cilia, etc., will actually filter those big particles. So these have to be particles that are small enough that can get to the very bottom exchange or distal exchange portion of the lung, which will then induce the fibrosis in the interstitium. That's point one. Point number two is that the fibrosis in the interstitium in these disorders is mediated by the macrophages. Basically what happens is these tiny particles come in, they get to the bottom of the lung, and in the very bottom of the lung, the distal portion of the lung, the only thing that you have to defend yourself there is the alveolar macrophage. The alveolar macrophage consumes those particles, and when it consumes them, it says, what the heck is this? I don't recognize this as anything. This is some foreign thing. I have no idea what to do with this. And so when it has no idea what to do with this, it freaks out and begins to start inducing fibrosis all over the lung, trying to basically wall off this garbage. And as it induces this fibrosis, that's what results in the interstitial fibrosis that you see in a pneumoconiosis. And that's why I say that the small particles have to be able to induce fibrosis by the macrophages. Obviously, they have to be small because they wouldn't be able to get to the bottom of the lung if they weren't small, and they have to be able to induce fibrosis. Now, because this is going to be a severe chronic disease, there's going to need to be a chronic exposure. If you had a little bit of fibrosis induced in a little area of the lung, that wouldn't really create clinical symptoms. So chronic exposure of some sort of occupational element, which is a small particle, which will then induce fibrosis, which is going to be mediated by the macrophages. Those are the pneumoconioses. Now here are a few high-yield ones, and I put them in a table. So the very first one is called coal workers pneumoconioses, and you can refer to your book. It might be a little hard to see on the screen. In coal workers pneumoconioses, the problem is carbon gets taken in as they're working in coal mines, for example, and as this carbon comes in, it gets into the macrophages, and the macrophages don't recognize what to do with it. They begin to induce fibrosis, and you get massive fibrosis of the lung. Now, of course, coal workers are chronically exposed to this, potentially. So that results in massive fibrosis of the lung, and that is called coal workers pneumoconioses. Now, classically, what that would result in is something called black lung, where the entire lung is black due to the presence of this coal, and it would result in a shrunken lung because the entire lung becomes fibrotic. One of the associations with coal workers pneumoconioses is something called rheumatoid arthritis, which we'll talk about when we do your joint lectures. However, the association of rheumatoid arthritis with coal worker pneumoconiosis is also known as Kaplan with a C, Kaplan syndrome. So that's an important pathologic consideration. Now let me remind you that all of us are exposed to carbon just by breathing in the pollution from the air if you happen to be in a big city. And mild exposure of carbon occurs constantly, especially because of that pollution. If it's mild, it doesn't really do anything. It sort of builds up in the macrophages. And so when you have buildup of carbon within the macrophages, that's called anthracosis. And examiners like you to know that. So you can have anthracosis within the macrophages of the lung and within the hilar lymph nodes. Again, that is clinically not significant, but it is common among the vast majority of people because the vast majority of people are exposed to pollutants within the air. All right, so that's coal workers pneumoconiosis, and I've also in this context explained anthracosis. The next of the pneumoconiosis is silicosis, and in silicosis the idea is that there's exposure to silica. Now silica can occur if the patient's a silica miner. It occurs, for example, in sandblasters. There's silica in sand, and sandblasters are people that take sand and shoot it at brick at a very, very high pressure with the idea that the friction created by the shooting of sand against brick will actually clean the brick. So it's a mechanism used to clean the surface of buildings. And so a sandblaster, quote unquote, could actually get exposed to silica as well. Now, one important thing about silica, if you remember this, you're done. And that is that when silica gets in the macrophages, it impairs the phagolysosomes to form. The phagosome is the vesicle that's generated when macrophages eat to kill something, and the lysosome is where the phagosome merges in order to be able to destroy that thing. So what happens in this particular situation of silicosis is that the silica gets into the macrophages and impairs the formation of the phagolysosomes. Why is that important? Because it's the only pneumoconiosis, and this is the high yield point. It is the only pneumoconiosis that increases your risk for TB. Now, once you know that it increases your risk for TB, then you're also going to know where it commonly occurs within the lung, and it results in fibrotic nodules, usually in the upper lobe of the lung. So I use silicosis and its relationship with TB to also remind me that these patients are going to have fibrotic nodules in the upper lobe of the lung. The next of the pneumoconioses is beryllium, and beryllium can be seen in miners. It can also be seen in workers in the aerospace industry. Now, the idea with beryllium is that it results in non-caseating granulomas in the lung, in the hilar lymph nodes, and in other parts of the body, in other systemic organs. Now, guess what that sounds like? Non-caseating granulomas in the lung, in the hilar lymph nodes, and systemic organs. Sounds exactly like sarcoidosis. And it is kind of very similar to sarcoidosis. However, in this particular case, this is driven by beryllium. So this is what I call the knee-jerk questions on examinations, where they give you a classic history and you think that this is just sort of a slam dunk question, and so you quickly pick sarcoidosis, but actually they were hinting at beryllium. So if they tell you that the patient works for NASA or recently designed some sort of stealth fighter or something like that, then that would be a hint to you that maybe they're in the aerospace industry, and so you want to think twice about beryllium. Another important thing about beryllium, it increases the risk for lung cancer. But I would say the highest yield is that you get these non-caseating granulomas in the lung, in the hilar lymph nodes, and in other organs. The final pneumoconiosis that we want to discuss is asbestos. Now, asbestos fibers would be seen in people who are classically construction workers. It was used in construction at one time. Plumbers, it was classically used at one time to insulate pipes. And shipyard workers, where there used to be a classic exposure as well. Now, in each of these cases, the patient would get exposed to asbestos fibers, and what's important to know is asbestos does a couple things. It creates fibrosis in the lung, or fibrosis in the pleura, or cancer in the lung, or cancer in the pleura. That's my little way of remembering this. Fibrosis of the lung, fibrosis of the pleura, cancer of the lung, cancer of the pleura. So if you get cancer of the lung, that's the standard lung cancer, and it can also cause cancer of the pleura, and remember that cancer of the pleura is called mesothelioma. Now, there is a high-yield association, which I've already talked about in your neoplasia lectures, and that is patients who are exposed to asbestos are much more likely to get lung cancer, than they are to get mesothelioma. And I've written that here just to remind you because it is so high yield. When patients have exposure to asbestos, it requires a confirmation, and the way by which we can make that confirmation is we can pathologically look for something called asbestos bodies. And asbestos bodies basically look like this. You get this long rod-shaped particle, which classically has little brown beads on it, and these little brown beads, they represent iron. So there's iron depositing on this rod, and this is also called a ferruginous body. And so that's another name for this particular particle, but essentially this represents asbestos within the patient. And so that's a pathologic way by which we can confirm the fact that the patient is exposed to asbestos. So those are the 4 pneumoconioses, and I've told you what I think to be the highest yield for each of those individual pneumoconioses. Sarcoidosis is another disease that can result in granulomas within the interstitium of the lung, and those granulomas would result in restricted filling of the lung. Remember that sarcoidosis is a systemic disease characterized by non-caseating granulomas in multiple organs. The most commonly involved organs would be the lung and the hilar lymph nodes, as I'll highlight momentarily. Classically seen in African American females, we don't know what causes it. It's probably some unknown antigen with a CD4 positive helper T cell response. Here's what the granulomas look like. Here I've illustrated for you, this is the lung, there's an airspace here, and then you've got this pink region here of epithelioid histiocytes. Remember that the defining cell of a granuloma is an epithelioid histiocyte. In addition, you have some of the characteristic cells, for example, these giant cells. So this is the classic granuloma. It's non-caseating, which means that all of the cells present within the granuloma are alive. There is no necrosis. One of the characteristic findings that can be seen in the granulomas of sarcoidosis is something called an asteroid body, and this is what we mean by an asteroid body. It's just a funny configuration of some of the giant cells, and it's one of the characteristic findings in sarcoidosis as well. The granulomas, as I've said, they most commonly involve the hilar lymph node in the lung. Involvement of the lung is going to then create it's going to create an interstitial problem, and that interstitial problem will lead to a restrictive lung disease. Basically, the lung becomes less compliant due to all of the granulomas present within the interstitium. Of course, the granulomas can involve multiple organs as well. So if it involves the eye, you get uveitis. If it involves the skin, you can get cutaneous nodules. It can involve the salivary glands and the lacrimal glands, so it can mimic Sjogren's syndrome, and this is very important because, again, it's sort of the knee-jerk questions that show up on exams. They expect you to jump for Sjogren's syndrome, but actually they're talking about something different, and in this case they're talking about sarcoidosis. So just remember that it can involve the salivary glands and lacrimal glands, giving you the classic, "Doc, I can't chew a cracker, and there's dirt in my eyes," and an increased risk of dental caries. Those are the classic clinical findings in Sjogren's syndrome. And so you could actually do a biopsy and see non-caseating granulomas, and if you have non-caseating granulomas with those symptoms, that is sarcoidosis. That's classic for sarcoidosis, I should say. And again, almost any tissue can really be involved. I've just told you a couple of the high-yield associations. Now, the way that these patients present is the most common sign is cough, but they can also have shortness of breath due to that restrictive lung disease that's going to be created by the sarcoid. Another very important finding is an elevated serum ACE. This is classically seen, so the angiotensin converting enzyme can be elevated in the blood. The patients have hypercalcemia. This is important. They like to ask you why. So the hypercalcemia occurs because the granulomas have 1-alpha hydroxylase activity, and they can activate vitamin D. Now, although we classically apply this to sarcoid and say because they're activating vitamin D, there's going to be hypercalcemia, in any disease in which the patients have a ton of non-caseating granulomas, for example, there will be activity, excess activity of the 1-alpha hydroxylase, which will then result in the production of hypercalcemia. So, for example, if a patient was exposed to beryllium and developed a very similar picture to sarcoid, and they also have hypercalcemia, that's okay, because it's the non-caseating granuloma that actually has the alpha-1 hydroxylase activity that's resulting in that hypercalcemia. The treatment is steroids, but what's interesting is that often this disease will resolve spontaneously without treatment. The final restrictive disease is hypersensitivity pneumonitis. And the idea here is that a patient gets exposed to some sort of inhaled organic antigen. It could be, for example, the feces of a bird or sometimes feathers, etc. And that results in a granulomatous reaction to that antigen. Now, when there's a granulomatous reaction to that antigen, the patients will present with fever and cough and shortness of breath, usually hours after the exposure, and this will all resolve if you remove the exposure. Now, the initial consequence of being exposed is that the patient gets fever, cough, shortness of breath, and then they move away and they get better. However, if the patient is constantly exposed, then that would result in a interstitial fibrosis, and that's why we're talking about it in this particular section of your text. Now, so some examples, pigeon breeder's lung, if a patient is breeding pigeons, for example. But what's important to note is that you get a granulomatous reaction in the lung. Now, in this case, you're going to get a granulomatous reaction, but what's going to be associated with the granulomatous reaction? Eosinophils. Again, it is a hypersensitivity pneumonitis. So classically on the slide, you would see granulomas with eosinophils. So that's the end of that section, and we're going to move on to pulmonary hypertension in the next section.